Wait, are they seeing?
So yeah, they need to see. Yeah. Oh. Anybody on Zoom that still, just make sure you guys are on mute. And otherwise, if you have any questions or issues, throw them in the chat. But we are recording, and today is October 6th, 2022. And we have Dr. Nicole Pohl here talking about corneal abrasions. Thank you.
All right. Hi, everyone. Thanks for having me today. I'm Nicole, as mentioned, everyone's favorite PACU resident for the last 2 weeks. And we are going to be talking about corneal abrasions today. Hopefully that doesn't mean we'll be seeing them. So I gave this talk to some of our residents recently as well. I just wanted to start off with a little anatomy review, just so we all kind of are on the same page. I will not be quizzing you about all these details of the eyeball that I don't know myself. But for the importance of this talk, important things to note. So the sclera, which is highlighted here, it's the fibrous protective coating in cases the choroid, which is our vascular layer, and then our retina, which is our sensory layer. The cornea is a part of the sclera. It's the clear anterior portion that allows light into the lens. And the cornea, for the purpose of this talk, is important to know it's composed of 5 layers of tissue, the outermost being the epithelial layer. And it has a high concentration of nerve endings supplied by the trigeminal nerve, which when we see patients with corneal abrasions is why they are so painful. A lot of nerve endings to this small little structure. So why are we talking about it today? Why is it important to us in anesthesia, also to you in PACU? Corneal abrasions are the most common perioperative ocular injury. They account for about 3 to 8% of anesthesia-related malpractice claims. As you all know, causes a lot of discomfort and pain in PACU, and sometimes more so than any of the surgical pain that patients are experiencing. It can increase the length of stay in PACU, and one of the really important things is that while a corneal abrasion is usually pretty benign and gets better over a short period of time, it's important that we make sure it's not another serious ocular emergency that can lead to long-term blindness or eye damage. So risk factors, there's risk factors that we can talk about for probably primarily for us in anesthesia, but also for nursing out in the PACU and the recovery area. One major risk factor, undergoing general anesthesia. So any of our patients that are getting GA are at risk. Surgery lasting longer than 3.5 hours puts patients at a higher risk. Laparoscopic or robotic surgery. So if you have patients that are undergoing laparoscopic and even particularly a robotic surgery, you don't have the surgeon standing over the patient. So when we work at the VA, we put a special foam pad and goggles over the patient's eyes to be extra careful because you have robotic arms that are kind of swinging in, a little bit more risk of hitting a patient's face, causing harm. Advanced age is also shown to be a risk factor. So some of our more elderly patients. And then positioning. Lateral positioning, as you can see here with my dog Bowser, at more of a risk of corneal abrasion. Prone positioning and Trendelenburg. I don't know if any of you have worked in the ORs, but when we do these flips and we position patients, it can be very hectic. Surgery is trying to get everything going. We're trying to make sure all of our monitors are on. We have patients' eyes that are taped, but when we're adjusting these positioning, there's definitely higher risk of hitting the eyeballs, causing some issues there. So presentation, I don't know if you guys want to like participate or not, but you probably seen this more than any of the anesthesia residents I talked to earlier on this talk. Any like particular symptoms that you've noticed? What's kind of the presenting things that you see in patients that will get a corneal abrasion?
Or they're just like yeah, they're just really. And then I then like sharp pain.
sharp pain like over the eyeball. Yeah. Yep, definitely. Those are a lot of things we talk about. We highlighted for us that like foreign body sensation, that gritty.
Like sandpaper.
Yeah.
Yeah.
Has anyone had like a corneal abrasion? Have you? Okay. And then did it get better? Like,
Well, I had to go see someone and they like gave me eye drops.
interesting. Okay. So that's like the big thing to highlight, like you said, is just that like that scratchy, painful, like right in the front of the eye, feels like there's a foreign body in it. As everyone's mentioned, there can be significant tearing, pain with blinking. Patients might not want to even try to open their eye. I'll just keep them shut. There can be light sensitivity. There can be some blurred vision. And then I guess signs going along with that. You can see more so just like a scleral injection. So just kind of redness of the sclera, frequent blinking, that tearing, tendency to keep the eye closed and try not to blink it. All common things that we'll see with corneal abrasion. But as mentioned, kind of highlighting in on that symptom, the sensation of a foreign body, the gritty, the sandpaper, kind of gets us to why we want to think about that, is getting to ruling out other issues. So we always talk about our differential diagnosis, and we can go through some pictures, but the first thing to kind of, if you're hearing a patient that's saying feels like there's something in their eye, what's kind of something else that you think about other than corneal abrasion? Maybe there's something in their eye. Yep. So foreign body, some ocular emergencies that we would worry about would be acute angle closure glaucoma. It's not something we're necessarily going to see here a lot, but you talked about working in the ER. Is it something you saw in the ER?
Yeah.
Open globe injury, so actual like significant damage that happened in the eye, maybe during a robotic surgery or something. A cavernous sinus thrombosis, and hyphema. So we'll kind of go through some of the things to look out for in these. Anybody have an idea of what this is showing? Yeah, so differently from the corneal abrasion, where you have kind of scleral injection, you have more of a little bit more angry eye, and the pupil is, they call it mid-dilated, so it's kind of fixed, it's dilated, not like overly. This is acute angle closure glaucoma. And patients, aside from having this, they can have some blurry vision, have redness of the eye, have significant eye pain, but not that like sensation of something being in there or scratchy, but more of just like overall total like pain over their eye, can cause a headache. What happens with acute angle closure glaucoma is the anterior chamber isn't able to drain aqueous humor as it usually is supposed to, and so you can get a buildup of that aqueous humor, causes increased pressure in the eye. And it's an ocular emergency. It's important to call ophthalmology right away to help try to reduce that pressure, because prolonged period of increased intraocular pressure can lead to eye damage and blindness. So one of the things if you hear some eye pain, it's important to check pupils, make sure that they're equal and both reactive similarly. This one is also pretty. This is blood in the anterior chamber. We can go back to our picture of the eye, but I'm realizing my mouse is not over here. But basically, blood that's accumulating here in the anterior chamber, and then also with the glaucoma, you'll get a closing off of this like. I can't even tell you the anatomy structure, but where aqueous humor is supposed to be draining is in kind of this range, and so you're not getting closure. But then for our next one, the anterior chamber, we're thinking about this region here. And you see our picture of blood in the anterior chamber. This one, anyone know what this is? I didn't know before the talk. It's a hyphema. and also is another ocular emergency. The big things that symptom-wise is really just kind of taking a look at the eye, and if you see that that blood in the anterior chamber, something to notify ophthalmology right away. It can be a serious emergency.
How, you know, how quick does that happen?
That the blood accumulates.
Yeah.
If it was like a serious bleeding, like something is actively bleeding into it, I would imagine it's probably pretty quick. This could be just due to a blood vessel that did get damaged, or maybe a direct blow to the eye that caused damage. I don't know specifically.
Yeah.
And then any guesses on this one? I guess it's under in my reference there. This is a close-up view of a corneal abrasion. So you can see this kind of abrasion. It's the epithelial layer of the sclera. A lot of nerve endings here can cause significant pain, as we know, but it kind of looks like this. Other things that I listed in the differential diagnosis, like a cavernous sinus thrombosis, so can lead to more of a proptosis, the eye swelling, blood not being able to drain out of the eye, can increase the intraocular pressure as well, differently than angle closure glaucoma, but another thing to think about. So in making the diagnosis of a corneal abrasion, it's important to do a careful history, ask about those symptoms. It's important to get a good physical exam. So looking at the appearance, checking your pupillary reflexes, checking their visual acuity, checking how well they're able to move their eyes. If extraocular movements aren't intact, you could think more about maybe the thrombosis range of things, or something that's a little bit more systemic. It's also important to compare to the non-affected eye. So taking a look at the other eye, sometimes your patients will only won't want to open the other one. So before you kind of disturb them too much, try to look at that first one, see what it looks like, the one that's not affected, and then try to help them looking at the second eye. And then just watch out for the red flag symptoms. So if you're seeing significant pupillary changes, you know, actual vision loss other than just kind of some blurry vision, systemic symptoms like headaches and things like that, definitely things to key in on and notify one of the PACU members right away. And then kind of Trish and I were talking about this. So when we talk about treatment and get to treatment, why do we not here in PACU use numbing drops? And corneal abrasions are only confirmed on diagnosis by a fluorescein exam. And so in the ED where they have this and use this and diagnose corneal abrasions, you can be pretty confident and pretty sure in the diagnosis. And while we can be pretty confident in our diagnosis of a corneal abrasion, we're not definitively diagnosing it here in PACU. It's more of a suspected diagnosis. So the things to do if you suspect it: notify a primary anesthesia team or the PACU member. As the PACU team, will notify the primary anesthesia team, the surgical team, or we'll kind of work together to do so. Treatment that's really been shown to be effective is really supportive care. Instructing Tylenol, ibuprofen when they go home. We can give them saline eye drops to kind of help keep things moist. But there's not a whole lot of strong evidence for antibiotic eye drops, although some people will still do them. Patching, not a lot of evidence that it's going to improve outcomes, even pain scores. There's been some looking at like topical NSAIDs and analgesics as well, and hasn't shown significant evidence to kind of improve the length of healing. Should also instruct patients not to use contacts for a week if they wear contacts. We'll give the patient letter that has kind of all of the information on what they need to look out for. But one of the most important things to tell patients that is if it doesn't get significantly better, it may not be fully improved in 24 hours, but if it doesn't feel significantly better in 24 hours to 48 hours, that's when they need to contact an ophthalmologist and make sure that's not something more serious. And that's kind of why we don't necessarily go right to as far as I understand, the numbing eye drops is we don't want to mask something else that it could be when this is going to improve in 24 hours and can kind of limit pain with some Tylenol, ibuprofen, and other things. I know it's very just uncomfortable for patients, but we're not making that definitive diagnosis here in PACU. So prevention, are there any like particular techniques that any of you use when patients come out to PACU to prevent scratching the eyes and such?
The constant reminder, don't touch your eyes, don't touch your eyes.
Yeah.
Put washcloths on their eyes before at least there's something there that they will prevent from like getting their nails or something. I've had patients that, particularly women that had long nails, that you're just like, oh, like don't, like don't touch them. And so it's hard when they don't understand, you know, they're still drowsy. But if you can divert them.
Pretty much, yeah. So for us in the OR, as soon as we put a patient to sleep, we're taping the eyes. There was a question about using ointment as well as tape. And again, that's something that has been shown to be, I have a lot of evidence behind it, that it reduces the risk of a corneal abrasion. There have been a few attendings that have swear that sometimes we don't tape the eyes fully shut, and maybe a corneal abrasion is more so due to just drying out of the eyes during a longer surgery because the eyes aren't fully shut when we tape them, and can cause a higher risk of that. Frequent eye checks, reassuring the patients. I've also heard people talk about the pulse ox, putting it on like the non-dominant hand, because people are more likely to reach up with their dominant hand, or even if you have to put it on the dominant hand, putting it on like not on the pointer finger, on a different finger, because any instruments that are coming towards the face are going to be a little bit more, I guess, concerning to cause a corneal abrasion. But mostly just constant vigilance, keeping an eye on the patient. You don't want to end up like Professor Moody. And for us in the OR, it's just we are supposed to do eye checks every 15 minutes and document that we've checked the eyes. And so when we're in those kind of prone cases, it's likely hard to see them. And so just getting a feel for the eyes, kind of things that we do, making sure that they're not being squished by some of the protective padding that we are using. It's pretty easy to check them when patients are supine, but being extra careful, like I talked about in those like specific positioning. I guess other things when they come out to PACU too is the O2 face mask as well. Just being aware of kind of sometimes it coming up into the face. I know that happens a lot. Something that we have to watch out for as well with transport and things. Any questions? That's really all I have to talk about. Yeah. That's a good, like, no tape at all.
Was that what procedure is that IR? I guess the yeah. I think know what he said.
Yeah, usually they put when they board for cases, they put way right now, so they know that they can't put a tape. But I think it was probably it wasn't reported, it wasn't there. They forgot. They here they put the person found out and he had to report it right away. So I was just trying to know what to do instead of the tape. If that's the case.
Yeah.
You could use Coban, like I don't know. I don't know what you guys get.
Do you know? Yeah.
I'm not familiar with that procedure, why there's not certification to it.
They can have
Like when we
any
put the IV in, we put cold banner on it, but people who go permanent scar.
And this is because
Of the
Some sort of injection rather than a take down. Like they put the leaves on the back, and they have to keep them on.
Clear with that. Other strategies you can do for people with eyes is to leave them untaped. Typically, if we do leave them untaped, then we will use some ointment, as long as they're under general anesthesia, or just eye drops to help lubricate that. I've seen that done, every 30 minutes, every 60 minutes. There are things that we use, especially for people that have been prolonged ICU stays that unfortunately just kind of have like that huge eye open, they're just sedated constantly, and we don't take their eyes then obviously. And when we have that, they get horrible keratopathies. So there's something called an eye moisture chamber, which is basically just like giant goggles that it's almost humidified. I suppose you can use that, but I don't know specifically for that procedure what's done. Those would be a couple options.
Any other thoughts or things that you've come across? You've seen more corneal abrasions than I have, probably.
But there are some people who also like receiving that initially here.
Yeah, I think that's a good start too. If there's like something in the patient's eye to kind of help wash it out and make sure it's not a foreign body.
Like the art,
The dropper.
Yep.
yeah, will be dropping here and, oh yeah, it's better, and it evens out a little bit with the particles and things, so I use that for the patient.
Definitely, yeah. And that's what we would usually just kind of tell people is just use drops like that. Yeah.
Sometimes the cold, like a cold washcloth too, I've done that. I don't know if that's more of a diversion technique too, but just like if they're complaining of their eyes, I had them put washcloths on, just while they're in PACU. Anything they can think of like that's soothing to help alleviate some of that. But it can be pretty significant, like Courtney said, like you feel like you can't open your eyeball for 24, 48 hours. The letter that you guys send, that just has instructions of like.
It describes what a corneal abrasion is, instructions on the supportive care, Tylenol, ibuprofen, contact lenses, and then there's a number to ophthalmology and instructions on if it doesn't get better in those 24 to 48 hours to call them. There might be like one other bullet point, but those are the highlights, yeah. Cool. Well, thanks, everyone.
Thank you. I don't know if there's anything in the chat. What are your pictures?
So this is at the first football game of the year with my dad. You can tell he's a little bit of a Michigan fan.
Nice.
This is my husband and our dog at graduation, and then this is at my parents' house in St. Ignace. Our dog passed out. Yeah. So yeah.
Your dog is so cute.
It's Bowser.
Bowser.
Bowser, yeah.
Oh, Bowser.
Yep.
It's so cute.
Yeah, he's a spoiled one.
Oh.
Yeah.
I know.
Nice clothes.
I'll stop it.